So I want to talk about personality disorders. I call personality disorders the common bizarre behaviors because these are things that we see. Personality disorders, while they are, relatively rare, are not so rare that you won't see these kinds of things. And I'll talk a little bit about the different kinds of these kind of things. But we really should be looking at these. In one case, we want to be able to distinguish the bizarre behaviors we're seeing from a personality disorder. Or we want to be able to see that maybe a bizarre behavior may be the emergence of a personality disorder in a specific culture. And so this is very useful for us to know about these things. And personality disorders, people who suffer from personality disorders have emotional patterns and behaviors that usually seem bizarre or strange to the majority of people. And they're not necessarily explicable by the immediate environmental stimuli, or environmental context. Now the DSM5, that's the latest one, defines personality disorders as ingrained patterns of relating to other people, situations, and events with a rigid and maladaptive pattern of inner experience and behavior. Usually dates back to early adolescence or early adulthood, but that's when the behaviors emerge in adolescence or early adulthoods. Those of us who are more psychodynamically and developmentally oriented will tell you that a lot of these personality disorders really have their genesis in early childhood. And the behavior related to these maladaptive patterns manifests in at least two of the following ways: through cognition, affectivity, which is emotional states, interpersonal functioning, and impulse control. So this is what we see, where we see the problem areas manifesting. Okay? Thinking, emotions, dealing with other people, and controlling a person's ability to control their own behaviors. So one thing we can ask ourselves is, what is personality? What is personality? And personality typically refers to those aspects of a person's characters that are not transient, i.e. traits, as opposed to states. Right? States are how you're feeling right now. So I got up this morning, I didn't have my coffee, I have to go to school, so I'm kind of grumpy and snappish at people. Well, that is a state. It's a state because it's a state of not drinking coffee. It's a transient thing. I go have my cup of coffee and now all is right with the world and move on with my day. As opposed to a state. A state may be, like, wow, I get to go and be in front of a room full of people, but I'm really nervous because I really am introverted. Being around a bunch of people really drains my energy, right? That's a state. I'm an introvert. Take the Myers-Briggs test. I'm an introvert. That's a state. That doesn't change. I can have 10 cups of coffee. I'll still be introverted, right? Doesn't matter. It's the states versus traits. So personality we can see as a complex pattern of deeply embedded psychological characteristics, i.e. traits, that are largely non-conscious and not easily altered. And they express themselves automatically in almost every area of our functioning. Okay? Now, as you might imagine, personality disorders are when we have problems with our personality. And they can be thought of as generalized and flexible patterns of inner experience and behavior. Patterns significantly differ from cultural expectations. By the way, that's been added to the DSM. They put something in about cultural relativity, because they realize that, like, culture-bound syndromes, what might be normal in one culture is abnormal in another one. So they have to put something about culture. These personality disorders typically begin in adolescence, early adulthood. That's when they manifest. They probably begin a lot earlier. They are long-term maladaptive patterns of perception, emotional regulation, anxiety, and impulse control. And the idea that the genesis of these things is in early childhood fits with the development of personality. You don't develop a personality, you don't start developing your personality when you're an adolescent. By the time you're an adolescent, your personality is pretty well developed. And so something that's going to affect your personality is really going to have to be something that comes along much, much earlier. Now, personality disorders lead to enormous personal and societal costs, lost productivity, hospitalization, significant unhappiness, imprisonment, and suicide. They cause a lot of serious issues. They are among the least understood and recognized disorders in psychiatry and psychology. They're among the most common of the severe mental disorders. And they frequently occur with other illnesses or other diagnoses, other problems, such as substance use disorders, mood disorders, anxiety disorders. And they also tend to be associated with people who are imprisoned. Many people in prison have a diagnosable personality disorder. I'll talk more about that. Studies that examine the traits associated with personality disorders have found those traits associated with specific disorders to be stable over time. We do find people with personality disorders that when they get older, in some cases the behaviors and things modulate a bit, not quite as bad. Somebody lives long enough, but they do tend to be stable over time. The pattern tends to be stable over time. So that's the way I understand these to really be long-term maladaptive patterns, and they pervade all aspects of a person's life. And they relate problems perception, viewing, understanding the external world, ability to regulate emotions, high levels of anxiety, and poor impulse control. So the same things on the list that we already saw. Now, based on the US data, via Canada, this comes from Health Canada. I should probably update the slide, but I think this has changed. We can roughly think personality disorders affect about 6 to 9% of the population. Yes?
How do personality disorders affect personality theories?
Not much. I'm not an expert on personality theory. I've taught that class once. I would say it's the other way around, that the way we think about personality theories affects the way we think about the disorder. Okay. Though, the DSM, I should mention the DSM really categorize things according to symptoms. It doesn't look at underlying causes. It doesn't even look at underlying causes to explain things. This is where, people who are psychoanalytically oriented or psychodynamically oriented sort of at odds with the DSM, because psychoanalytically oriented people, we like to look and figure out what causes these things, when do they start, usually in early childhood, how do they develop to the point where they start manifesting in adolescence. Okay? But you won't find that in the DSM. It's pretty atheoretical. But I would say that, probably, at least among psychodynamic people, we definitely look to see, what are the, what's the genesis of this thing? Where does it come from? And so, if you, for instance, you look at Freudian developmental theory of personality, you could see when that goes awry, when there's a problem with that, that's when you would get personality disorders. Okay? And you get other things too, like drug addiction. So I wrote a whole book on that, right? On how personality development goes astray, and then people end up, becoming addicted to drugs, right? And having a personality disorder. Okay, so those things go together. But yeah, it's usually that way. It doesn't usually go back the other way. Not that it shouldn't, by the way. That the clinical insight should be worked into the theories. I think more of that might be a little bit better, now that you mentioned it. Now, personality disorders exist in a bunch of different forms. We're going to talk about these. And their influence on interpersonal functioning varies from mild to very serious. Onset usually occurs in early adolescence or early adulthood, even though, as I mentioned, the genesis of these things happens much earlier. Antisocial personality disorder, which you would call psychopathy, or we used to call psychopathy or sociopathy, is found frequently among prisoners. 50% or more prisoners can be diagnosed with antisocial personality disorder. Yes?
Is that before or after they're in prison?
That's one of the problems, is that you could learn the behaviors when you're in prison. So I'm not sure that research has been done. I would assume that I think the big assumption is that people end up in prison because they have some kind of psychopathy, some kind of antisocial personality disorder, leads them to do criminal things, end up in prison. But I think it's a very good point that some people could learn that behavior as a coping strategy in prison.
Well, and prison probably exacerbates any.
And prison exacerbates, yes. Very good question. Look that up and let me know.
If you bring up ASPD, that's interesting, because that one in the DSM has earlier diagnoses for it. There are less severe.
Well, there are in the DSM there are diagnoses you give to kids that then later on you think they better watch that kid because he might end up being a psychopath.
In the research on OCD and CD tends to be that if you don't grow out of those, they tend to be developing into antisocial personality disorder as adults.
Yeah, we'll talk about that. I'm going to talk about some of the precursors. What are the causes of personality? We'll get into that a little bit. We'll talk about that probably next time. Hospitalizations for personality disorders in general hospitals. Sometimes you see about 78% are young adults between 15 and 44 years of age. So that's sort of the age range where personality disorders manifest most strongly. Older years, they still manifest, but the behaviors tend to be modulated a little bit. And younger, you don't tend to see as much younger. But actually, if you look at kids and you work with kids, you can see the precursors at a younger age. Okay? I have arguments with my psychotherapist friends about this. But a lot of personality disorders you can see, especially antisocial personality disorders, but even other ones, you can see the signs are there. The sex difference in personality disorder types. Antisocial personality disorder is more common among men, while borderline personality disorder is more common among women. Dependent and hysterical personality disorder is more common among women, but there may be labeling biases. Okay? So you're a woman, you show up in the clinic, you got a personality disorder, borderline, right? You're a guy, you show up, antisocial personality disorder. You may be manifesting very similar behaviors, because labeling biases definitely exist, and you have to be very careful about that. Yes?
By that bias, are you going to mention about the history of the institutionalization of hysteria and nymphomania?
I will talk about that a little bit, yeah. Back in the day, people had, I'll try to summarize what you just said in a really quick sentence. Back in the day, people with personality disorders, if you would bother enough people around you, right, because usually a lot of times personality disorders, you're bothering the people around you more than you're bothered. People around you back in the day could have you institutionalized. It's much harder now. They could have you institutionalized. They'd stick you in a place like Cambria State Hospital, and you'd be stuck here. Maybe you're going out too much at night. So your dad said, "Oh, you're a nympho. I'm going to stick you in the mental hospital. You got a disorder. Stick you in here," and then they would do various things to you to try to cure you of those things, which we're going to talk about. Up to and including things like lobotomizing you. Okay? So yes, there is definitely a history of that. And again, many famous people who were sent to mental hospitals like this one, or lobotomized, and there's a number of them. Many of those people had personality disorders, and they weren't psychotic or whatever else, but they were a behavior problem. And so, a lot of these treatments were really basically to deal with managing warehousing of people as opposed to treating the actual illness. Okay? Now, personality disorder is also associated with a history of alcohol abuse, drug abuse, sexual dysfunction, generalized anxiety disorder, bipolar disorder, obsessive compulsive disorder, depressive disorder, eating disorder, suicidal thoughts, on and on and on and on and on and on and on. So a lot of things, psychological problems are comorbid with personality disorders. Okay? Mentioned about half of prisoners can have an antisocial personality disorder. And again, other things, associated things, substance abuse, violence, vagrancy, things that lead to criminal behavior. Other social consequences of personality disorder, we see spousal violence, domestic violence, child maltreatment, poor work performance, suicide, suicidality, gambling. And again, I mentioned substance abuse above. Substance abuse also very common. Other maladaptive social consequences of personality disorders include decreased academic performance, domestic violence. Here's the picture here. Chris Brown and Rihanna. Child molestation, sex offense, incarceration, again, poor work habits, performance, again, pathological gambling, again, et cetera, et cetera, et cetera. People diagnosed with one personality disorder often suffer from other personality disorders. That also may be due to the imprecise diagnosis of personality disorders. There's a lot of overlap between personality disorders. And so you may diagnose somebody as this, I may diagnose them something else, so we just give them two diagnoses. Okay? So that partly of that. Partly that they're very difficult to distinguish from one another in many cases. Causes. So I'm mentioning this a little bit today. I'll go over this again next time. Main cause of personality disorder is early childhood trauma. Okay? This takes the form of emotional, physical, or sexual abuse, inconsistent parenting, or parental neglect. Okay? These are the main causes of personality disorders. And again, it's not that you might find somebody who had personality disorder who had a perfectly good childhood. People like that do exist, but if you look at large groups of people with personality disorders and you start doing the research on them, you will find that most of them had some form of childhood trauma, early childhood trauma, usually a continual form, not just one time, but in some cases it could be bad enough trauma, it could be like a PTSD thing, but in many cases, most cases, it's going to be some sort of ongoing situation. Okay? A study of personality disordered outpatients who have less severe symptoms because they're outpatient found only modest relationships between specific trauma dimensions and personality disorder diagnoses. That would be expected because their disorder is milder. The general relationship between trauma and personality disorders is very high, even among these outpatients. Sexual and physical abuse were specific predictors of paranoid and antisocial personality disorders, while emotional abuse predicted borderline personality disorder. They did a lot of studies of borderline personality disorder. Does not seem to be genetically determined, though the characteristics of borderline personality disorder and, by extension, many other personality disorders do seem to have some heritability. So the disorder itself, the constellation of symptoms as the disorder, does not seem to be heritable. But the specific characteristics, personality characteristics, do have some heritability things. So things like aggressiveness, impulsivity, suicidal tendencies, emotional stability, these things have shown to be heritable. But you can have these things and not be borderline. Okay? But the idea is it suggests is that certain people, if they have sort of genetic predispositions to these things, and they come and they encounter abuse, you know, as children in a specific way, especially emotional abuse, emotional or sexual abuse, they could be more at higher risk for developing a personality disorder later. Okay. Yes?
Well, just because Chris Brown was on your recent slide, there's an article where he claims he lost his virginity at 8.
Yeah.
You're like, I don't think that's losing your virginity, that's being molested.
Yeah.
You know?
Yeah. I'm sure if we delved into his past, put him on the psychoanalyst couch, we could probably see where some of that, you know, I'm not saying it's personality disorder, but some of those violent things, you could probably see where some of that's coming from. Okay, so the rule of thumb is, and I'll leave you with this, the worse the childhood, the worse the personality disorder. Okay? The worse the childhood, the worse the personality disorder. It doesn't mean everybody who has bad childhoods ends up with a personality disorder. We have a lot of resiliency and variation among people. Okay? But when you look at people with personality disorders, they seem to have, for the most part, some sort of childhood trauma. I left you with the rule of thumb that the worse the childhood, the worse the personality disorder. Okay? And this has been well researched, it's been pretty typical. You can see, and if you're interested in the readings, you'll see my article, which is on personality disorders, and you can see some of the references for that, and you can look through those and hopefully convince yourself that this is the case. Okay? So we go to the DSM-5. Here are the general criteria for personality, for one of the personality disorders. Moderate or greater impairment in personality is reflected in self and interpersonal functioning. One or more pathological personality traits. Impairments are relatively inflexible. They're pervasive across a range of situations. Stable across time. Can be traced back at least to adolescence, early adulthood. And if you're more psychodynamically oriented like me, you look for the origins in very, very early childhood. Another psychological order does not better explain these impairments, nor the attribution of the physiological effects of a substance or medical condition. We're going to talk in a couple weeks about neurologically related conditions. And so you're going to basically rule a lot of these things out before you diagnose somebody with a personality disorder. And the impairments are not better understood as normal for an individual's developmental level or social or cultural context. This one has been added in. I can't remember if it was a DSM-4 or DSM-5, but actually now we really take into account that there may be cultural differences. Okay? That something that's abnormal in one culture may be normal in another culture. And this is very interesting. And this really means that we really need to know a little bit about other cultures, by the way. And so we're going to talk about some syndromes in this class that manifest in other cultures. Okay? Where you have a syndrome that you find only in certain places in the world, in certain cultures in the world, and it doesn't seem to occur in the same way in other cultures. And I'm going to go into a lot of detail about this later on. This is going to be something we'll dig into a little bit. You guys don't really know this, it's not that important. Personality disorders included in Section 2 and Section 3 of the DSM-5 due to complexity of disorder and various points of view on the disorder. Section 2 includes updated diagnostic criteria. Section 3 includes proposed research model for personality disorder diagnosis. So what this is the fact that the DSM-5 is a book that's put together by the community. You guys know what the DSM, the Diagnostic and Statistical Manual, it is the Bible, if you will, in quotes, by which psychiatrists and psychologists use to diagnose people mental illness. Put together mostly by psychiatrists, some input from psychologists. It is attempted to be atheoretical. It basically is, you look at a group of symptoms, and by the grouping of symptoms, that's how you decide whether somebody has some kind of disorder. It tries to be atheoretical, and some people think this is good, some people think this is not so good. Okay. And personality disorders, as I'm going to talk about more, are very, very squishy as far as a diagnosis. There's a lot of overlap between them. There's a lot of kind of non-specific things that are involved in personality disorders, and it makes these very difficult to really accurately describe. And so when they did the DSM-5, the latest version of it, they had the idea that they were going to revise personality disorder section. They were going to come up with a new, better way of looking at personality disorders. Maybe they were going to do it kind of like a spectrum, like they're doing for psychoses. They were going to, or like autism. They were going to come up with something new. And at the end of the day, they just couldn't really figure it out. I don't know if they couldn't agree on do it or not. So what they did is they decided to postpone revising personality disorders to a later version of the DSM. So I don't know if the next one that comes out, 5.1 or whatever, is going to be. They're now doing the revisions based like sort of like on computer programs. So we'll have 5.0, 5.1. So we don't know, but in the future we're going to see they're going to revise the personality disorder stuff. Personality disorder diagnoses pretty much left the same as DSM-4, pretty much similar. So we'll see what happens in the future. Okay? You guys don't need to worry about that. Okay. So here are the domains in the DSM-5 rating system. These are things they look at. Negative affectivity, negative emotions, that are usually frequent and very intense. And this can relate to trait facets. Okay. Emotional lability, you guys know what that is, lability? That means changeability. Emotions can change really rapidly. Anxiousness, separation, insecurity, which if you know anything about attachment theory, maybe you had a class from Dr. Baker, you learned about attachment theory. It's insecure attachment. Perseveration, which can be thought playing over and over and over in your head. Submissiveness, hostility, depressivity, suspiciousness, restricted affectivity, kind of restricted emotional range. These all can be partly used to understand personality disorders. Now you're seeing the idea I was talking about before. A lot of these things can also be used to understand a lot of other disorders as well. Okay? So this is where it's difficult to really tangle out personality disorders. Next one, detachment, involved withdrawal from other people and social interactions. Traits may be restricted affectivity, again, depressivity, suspiciousness, i.e. paranoia, withdrawal, anhedonia. Anybody know what anhedonia is?
It's the lack of finding joy in things that you.
A lack of finding joy or pleasure in things, yeah. Okay. My life over the last week, yes. And intimacy avoidance. Antagonism. Behaviors that put the person at odds with other people. Traits like manipulativeness, deceitfulness, grandiosity, attention-seeking, callousness, hostility. Disinhibition involves engaging in behaviors on impulse without reflecting on potential future consequences. And compulsivity is the opposite of this, by the way. Yes?
Speaking of over the past week, can we talk about that supermoon?
Supermoon. Did you guys see it?
Yes.
I didn't see it. I didn't get up early enough. Did anybody's behavior change? Because the moon.
No, I turned into a robot.
Yeah.
I'm an ear nurse, and I will tell you that it's absolutely true that full moon just brings people.
Yeah. So this is something, if you talk to ER nurses, and you talk to people like me, who worked in a locked-in facility on the graveyard shift with mental patients, summertime, during a full moon, absolutely bat SHIT crazy. I mean, we'd have a place where like on a normal night, maybe 1 or 2 patients wouldn't be able to sleep and they'd be wandering around. On a full moon night in the summer, we'd have, our facility held 100 patients, we'd have 99 up wandering around agitated. We tackled more people and shot them up with Thorazine on full moon nights than, I mean, it is just absolutely nuts. And so workers, especially shift workers, people who work late nights, you see this, and yet supposedly now this has been scientifically studied and debunked. But I bet if I went out, pulled a bunch of nurses and psych techs, and from anywhere in the world, and we compared, we would see there's a full moon. And, you know, people, you also think, well, it's just lighter out, so people, you know, just because it's more light, they don't sleep as well. There may be some perfectly rational explanation for it, but it's definitely a phenomenon that I saw on a regular, systematic basis. Very, very, very common. So I don't know, maybe the supermoon, you know, maybe people got superpowers and, you know, I don't know, turned into werewolves or whatever. I slept through it, so, you know, one of the consequences of having a teenage child is that I did not get to bed early. I have to wake up to see it. I was told it was very beautiful, so you can see pictures of it. All right. So disinhibition could be the moon. You know, we're going to talk about werewolfism later on. Psychoticism involves unusual and bizarre experiences, traits like unusual beliefs, experiences, I would say delusions, eccentricity, cognitive and perceptual dysregulation, etc. So these are the personality domains. These are the things that are going to underlie personality disorders that we're going to look at. And here we can start looking at the actual personality disorders. We're going to go through these in detail, so I won't look at them here because it's really hard to read this slide. But we're going to start talking about I think there's 10 of them, 10 personality disorders. Okay, antisocial, avoidant, borderline, narcissistic, obsessive compulsive, schizotypal, et cetera, et cetera, et cetera. Okay, so the 10. So let's talk about these in general. Antisocial personality disorder, lack of regard for the moral or legal standards of the local culture, marked inability to get along with others and or abide by societal rules, sometimes called psychopaths and sociopaths. So I was talking on Wednesday about this, and in that class I did not make a distinction between psychopaths and sociopaths and antisocial personality disorder. Okay? The new name, the official name is antisocial personality disorder. However, people in the psychology world, especially researchers, still use the term psychopath and sociopath. Okay? If you decide to go on to graduate school and get a PhD and do research on psychopathy, you will use the term psychopath. Research on prisoners, you will use the term psychopath. Okay? The difference between sociopathy and psychopathy is a little subtle, but it's worth you knowing about it, even though I'm not going to really talk much about that in this class. The difference is that in the past, sociopaths are thought to do these sort of behaviors, these antisocial personality sort of behaviors, because they've been conditioned by their environment. In other words, you grew up in a really bad place. Say you grew up somewhere like in LA in the middle of a gang-infested place and people were shooting each other and there were drive-bys going on and drug deals and, you know, you got beat up at school every day. You know, you may develop these characteristics, these sociopathic characteristics, sort of as a response to the environment. Okay. Yes?
I read a book that explained it like sociopaths are made and psychopaths are born.
Yes, very good. That's actually a very good way of putting it. Sociopaths are made and psychopaths are born. Psychopaths, in the traditional thing, are thought to basically have biological differences. Okay, biological differences. They're born with certain brain functionings that lead them to do these sort of behaviors. And so there's a distinction between these two things. Now, what do we know now about sociopaths and psychopaths is, of course, that the reality is more complicated. That you might be born with tendencies towards psychopathic behavior, which then, when you're put in a certain environment, modulates how much of the psychopathic behavior actually emerges. So say you have tendencies towards psychopathic behaviors, but you're born in a loving, non-abusive family, you know, living somewhere in a really nice place. Maybe you live in, I don't know, Laguna Beach or something, and, you know, everything is cool, and you don't experience anything that sort of triggers those tendencies to turn into overt psychopathic behavior. Okay? You know, so you don't become a psychopath. On the other hand, maybe you have some of the tendencies, but you end up being in a really bad environment, you're abused as a child, and so then you end up becoming diagnosed later on with antisocial personality disorder. So as we know with all these nature and nurture arguments, there's usually some of both. They're usually mixed together. So this distinction between psychopathy and sociopathy, in my opinion, is very artificial. And I don't think it's very helpful, in my opinion. I don't think it's very helpful. Because there probably are not any sociopaths that are purely just made into sociopaths. And there are probably not any sociopaths that are purely that way just because of their biology. There might be a few, okay? But in general, most people who evince this kind of behavior are some mixture of having some sort of tendencies to the traits and then being in some sort of environment that brings those out, okay? So that's the way I would look at it. And the research stuff I've been reading, actually some of this comes out of even profilers in the FBI, people like this. This is typically how they're sort of seeing this stuff now. It's really a combination of things, okay? Combination of things. Now, you may get sentenced to prison. You know, maybe you do something, you know, our criminal justice system is not perfect. You do something, maybe you don't do something, but you get blamed for a crime and, you know, the prosecutor's aggressive, railroads you through, you get sent to prison, and you may have to sort of act like a sociopath to survive in prison, okay? And so, you know, you would be labeled in the old days as being a sociopath. You get out of prison, you don't have to act that way anymore, you revert back to being a normal human being. You know, that's possible. And so in that sense, you might be considered while you're in prison to be a sociopath, okay? But that doesn't mean you have antisocial personality disorder. Okay? And my guess is that's probably pretty rare. Yes?
Sometimes they have psychologists go into the prisons and they have a psychopathic checklist.
Mm-hmm.
So
Yes.
they can actually
So there's a
figure
guy
out-
named, there's two guys that are really important to know, and I'll get more into psychopath stuff later. There's two guys, two researchers. One's name is Cleckley, who wrote a very important book about psychopathy. And the other one name is Hare, H-A-R-E. And Hare came up with this checklist, psychopathic checklist, where you go through and you can, I think actually the examiner is the one who checks off the things on the list. And it's pretty much a lot of the things that we're going to talk about here, are that the tendencies that you see in the person. When we talk about psychopaths, you just check those off, you see those events in the person. And it's pretty accurate. It's pretty accurate at diagnosing psychopathy. The other thing they're doing now with psychopaths is there's been a lot of research. There's a guy who goes around, psychologist, because I'm blanking on his name right now. He's been going around to prisons and doing MRIs of prisoners' brains. You know, about half prisoners or more are...
Oh, with the movable MRI?
Yeah, he takes a
Yeah.
portable MRI machine, which is very expensive, goes there, he MRIs their brains, and he can pretty reliably tell you who is at least a low-functioning psychopath.
I think it's Dr. Keel.
Keel, that might be right, yeah. And so he's published a lot of research on this. So at least low-functioning, impulsive psychopaths, you can see differences in the brain, okay? The other thing that's really coming out now, and this is something I've been reiterating for years, and there's now actually some consensus, I think, among people who study psychopaths, is that we're really starting to think about psychopathy not as, and I'm going to use the term psychopath, sociopath, and antisocial personality disorder interchangeably now, okay? And I'm definitely using psychopath. When I say psychopath, I don't mean somebody who's just born that way, but somebody who had tendencies who then was in the right environment that allowed those things to develop into this disorder. Okay? And I'm not going to use sociopath very much because I don't think sociopaths are just made, like real sociopaths. And once they get out of prison, continue to act that way. Okay? Does that make sense? So people with psychopathy, we're now starting to think of these people being along a spectrum. So you learn now in the DSM5 we have an autism spectrum. Those of you guys had 313, you learn about the autism spectrum. The Asperger's down here, it's pretty mild, and it goes all the way up to people who are very impaired, and there's a spectrum. You get, you hear this now, it's a common language. You get diagnosed on the spectrum somewhere, right? From, mild to much worse, okay? Similar thought now for psychopathy. That there's kind of like a spectrum of psychopathy. That you can be a high-functioning sociopath who not a serial killer, but maybe you become a CEO of a company and you're more than willing to, for instance, fire 10,000 people, and have them lose their jobs and their livelihood, because you're merging your company and that's just business and you don't really feel much, conscience or twinge of regret or guilt about that. Okay, that would be maybe a milder level. Up to the the more hardcore level where you have somebody who's a serial killer who really gets maybe sexual, sadistic enjoyment of killing people and feels like it makes me feel good, so I'm just going to do it. Right? I don't care what societal rules are. So you have everything in between. Yes?
So it's kind of like instead of sociopathy being a different thing, it's more like a psychopathy with epigenetic, like latency kind of thing?
So in a simple way, think of it this way. When I'm going to talk about antisocial personality disorder and psychopathy, it is a mixture of genetic tendencies, traits. You have traits. You may inherit the traits that tend toward these kind of behaviors, but you really have to have the right upbringing for these things to develop into full-on psychopathy or antisocial personality disorder. And we can think of sociopathy as people who develop antisocial personality disorder behaviors because of their specific situation. But I'm not going to use sociopathy very much because I think, to me, I don't think that's as useful. And we're not going to be talking about those people in this class as much. Maybe a little bit. I don't know. Okay? Yes?
There was like a neuroscientist, James Fallon, who was doing a study on psychopaths and serial killers, and like the brain scans, and like he found out that he had that brain.
Yeah.
And then attributed, like he didn't become them because of his upbringing.
The brain development is related to upbringing as well as inherited stuff. Okay? We know that. We know that kids who are abused or people who go undergo post-traumatic stress have changes in the brain. Okay, so it's really a mixture. It's really a mixture of nature and nurture. For the most part, most of the psychopaths that we are going to talk about and encounter in this class, it's a mixture of nature and nurture. Okay, it's both. There may be some examples where it isn't, but for most of them, it's going to be a mixture. Okay, so I think for this class, at least, think about them as being a mixture of these things. And we can debate, the level of mixture. And the level of the mixture may determine where you are on the spectrum. Again, the worse the abuse as a child, the more likely you are to have some disorder. So maybe you didn't inherit a lot of the tendencies toward being a psychopath, but then you experience this horrible abusive childhood. Maybe you develop some of the traits and it puts you somewhere on the spectrum. Okay? Or maybe you have a lot of inherited tendencies and you have an okay childhood, and you still end up being on this psychopathic spectrum somewhere.
Yeah, I think that's what he was like trying to get at.
Yeah, yeah. This is my understanding, and again, this is not my area of expertise. My understanding now is the people who study psychopathy, this is now generally the view.
Yeah.
Okay, this is generally the view now. And we may see in future versions of the DSM, they may actually make a spectrum and start, more formally like they're doing with autism. I would like to see that. I think that makes a lot more sense to me. It's not a light switch that goes off and on. It is a spectrum of behaviors. And again, I read an interesting book about psychopaths last year, and it talked about CEOs of companies, and saying that CEOs of companies, while not diagnosable as psychopaths, have a lot of psychopathic traits. For instance, the ability to fire 10,000 people and not care that they lost their jobs and can't feed their families anymore because they want to merge two companies and get a bigger bonus. And that's actually a real example, by the way. And it was in the book. It's very interesting. And the guy went and interviewed the guy, and he had absolutely no remorse about doing it whatsoever. It's just business, blah, 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 and he just went on his day, right? And yet people really suffered from the merger and losing their jobs, and it was unnecessary. But the guy got a bigger bonus for doing it. Yes?
Oh, two things. First, I looked it up. It was Dr. Keel.
Okay, good, good.
The other thing was for the dependent personality disorder.
Yeah.
Is it different if somebody's like the victim of abuse and they're caught in the cycle of abuse so they feel dependent on their abuser? Or would they be labeled also as someone with a dependent personality disorder?
Yes and no.
Okay.
It could be both. Yeah.
But
And
so
we'll get to that
it's
because
possible to be separate?
Because the problem here is a labeling bias.
Yeah.
Okay? So somebody comes in and they are, the pop psychology term is codependent on somebody.
Yeah.
They could have a dependent personality disorder. They could also just be in a bad situation that's really difficult to get out of. I actually had some patients like that. So you see this a lot in domestic violence.
Yeah.
People who are domestically abused, like a wife that's domestically abused by the husband, may be locked in the situation, And if they're able to actually get some therapy and actually separate, then they no longer have a dependent personality disorder. Somebody with dependent personality disorder would have to maintain some
It's
dependency
like more
on somebody.
stable.
They have to find somebody else, or they have to
Okay.
do it. It wouldn't be such a state. It would be more of a trait. And this is true for psychopathy and sociopathy. This is how I think about sociopaths. Sociopaths are not really a personality disorder because by definition that's a state, not a trait, right? I'm in prison, they put me in Pelican Bay, I didn't deserve to go there, I'm a regular person, but I got sent there, and now I gotta, make a shank and act like a psychopath, just to get, so I don't get, stabbed myself, right? So, but that's a state. Once I'm out of prison, mistake was found, I get let go, okay, I don't act like a sociopath anymore. That by definition is not a personality disorder. So in one way, my thinking, again, I think sociopathy, this traditional view of sociopathy, that's not a personality disorder because it's not a trait, it's a state. The same thing with dependent personality, right? I take that personality abusive relationship, are they now going to be dependent on somebody else, or are they now able to be independent and live their own lives? Is it a state or a trait, right? If it's a trait, I suspect personality disorder. If it's a state, I suspect it's just something else. Okay?
Makes sense.
That's how I think. That's how I would think about it clinically, if I was seeing somebody clinically. Okay? And we'll talk about dependent personality disorder in a minute. Okay. So, antisocial, avoidant personality disorder, marked social inhibition, feelings of inadequacy, extremely sensitive to criticism. Every time I teach this class, I start thinking I have one of these. And every semester it's different. This semester I'm thinking I have avoidant personality disorder. That really could be true. I don't know. Borderline personality disorder. This borderline personality disorder, when I wrote the article that you'll read, I write a lot about borderline personality disorder because this is the personality disorder that tends to be one of the catch-all diagnoses. Okay? Because a lot of things in borderline personality disorder you find in other personality disorders tend to be catch-all diagnoses. It's also a very common diagnosis among the personality disorders. So this is one that gets a lot of attention. There's been a lot written about, a lot of research done on it. It is, again, very nebulously defined. But one of the main characteristics is a lack of a stable identity. Okay? Rapid changes in mood, intense, unstable interpersonal relationships, marked impulsivity, instability in emotion, and in self-image, in knowing who they are. And so borderline personality disorder is really quite interesting. I've written a lot about this. My book on drug addiction, I talk a lot about a lot of addicts having personality disorders, and a lot of addicts have borderline personality disorders. Very common. You'll find substance abuse is a very common corollary with borderline personality disorder, as with some of the other ones as well. Okay? So we can talk more about that. We could do a whole class in Freudian theory, and we could talk a lot about borderline personality disorder. We're not going to have that much time in this class to get into it, but I will point out a few instances of things where you can see some maybe possible relationship with borderline personality disorder. Now, dependent personality disorder, we were just talking about extreme need of other people to the point where the person is unable to make any decisions or take independent stand on his or her own. Fear of separation and submissive behavior, marked lack of decisiveness and self-confidence. So this is a behavior you sometimes see clinically, and again, clinically, when I used to work for the California Victims Witness Program, where you get the state pays for psychotherapy for somebody who's been a victim of a crime, and a lot of the crimes that came into the office were people who were domestically abused. So I saw people with domestic abuse problems, and so you see this there, right? They get out of one relationship and immediately get into another abusive relationship where they're super dependent, usually with somebody who's kind of psychopathic. That person, you might wonder about dependent personality disorder. If they get out of the relationship, they're able to pull themselves together, not be in another abusive relationship, then you think, well, that's not dependent personality disorder. It's something else. It's kind of a neuroses or something, or they were in a bad situation, whatever it might be. So again, dependent personality disorder, this is going to be more of a stable kind of interaction, especially with other people. Okay. Now, when we start talking about bondage, discipline, and sadomasochism, you can ask yourself if somebody who identifies as submissive, if they are doing this from a kind of just, I like being submissive, or like they have a personality need to be submissive and dependent on somebody. This is where if somebody came into my office and they told me they did BDSM, I'd say that's fine and I don't care. But if they told me they were submissive, I might think, are they submissive in other relationships in their life? And then I might start thinking about dependent personality disorder. So that might be an area where you might see some crossover. Okay? Not all submissives have dependent personality disorder. Not all people with dependent personality disorders practice BDSM. But there could be a little Venn diagram overlap with those two things. Histrionic personality disorder, we live in LA, so we see a lot of this. Exaggerated, often inappropriate displays of emotional reactions. Anybody watched Housewives of Orange County recently? Approaching theatricality in everyday behavior. Sudden and rapid shifting emotional expressions. Next, one of my favorites, and a subject of national and international concern right now, narcissistic personality disorder.
Maybe a little, huh?
Behavior or fantasy of grandiosity, a lack of empathy, a need to be admired by others, an inability to see the viewpoints of others, and hypersensitive to the opinions of others. I'm so interested in this, I'm going to give you a whole separate lecture on narcissism, because it's very interesting. Also, I will say that there are people with narcissistic personality disorder who have a high degree of overlap with people who are psychopaths or who have antisocial personality disorder. And there may be a mixture of these two disorders, which we see in some national leaders. I'm not talking about the person you think I'm talking about. I'm talking about Hitler and Saddam Hussein and Pol Pot and some of your really, really nasty dictators. Okay, there's a few up-and-coming ones that I think that are out there that I worry about. Recep Erdogan in Turkey is a good example. He's a guy, Vladimir Putin, possibly. So we can talk a little bit about that. Very interesting area to study. My dad is a psychoanalyst. He's an expert in narcissistic personality disorder. He's written some actually really, really good stuff about some cases on this. And when I teach this class at the graduate level, or I teach a graduate level class on psychoanalytic psychotherapy, theories of psychoanalytic psychotherapy, we go in a lot of detail about those cases. It's really quite fascinating. I go on and on about narcissism. I'm going to get to that, so hold on to that. We'll talk a little bit about that. Yes?
Where do you teach the postgrad class?
I taught that at Cal Lutheran. I no longer teach that anymore there. That's a long story, which I'm happy to regale you about over a cup of coffee or something if you really, really want to get bored and get into Kevin's weird avoidant personality disorder characteristics. That extreme, sensitivity to criticism come into play there. That's all I'm going to say. All right. Obsessive compulsive personality disorder, characterized by perfectionism, inflexibility, preoccupation with uncontrollable patterns of thought and action. Okay? The big question here is, how is obsessive compulsive personality disorder different from obsessive compulsive disorder? Okay, OCD, right? It's different from OCPD. Okay? Anybody have an idea?
States and traits.
This is pretty.
Kind of, but people with OCD, a lot of them, it really appears like a trait. Okay? Yeah.
The OCD might only pertain to one or two things, whereas this is more general, can
Very
pertain to
good.
lots of things.
Very good. Very, very good. Very good. He's hit the nail on the head. That people with OCD may have OCD sort of behaviors and compulsions, and they may be centered around one thing. But people with OCPD have a general sort of personality that's obsessive compulsive. So they may have obsessive compulsive behaviors or thoughts or whatever about a lot of things in their life. And the OCPD person may not be as, they can be, but they may not be sort of as like hardcore, like, oh, every time I walk by her, I gotta go wash my hands, It may be that instead of every time I go by her, I gotta wash my hands like an OCD person. I may just, have a need to always sort of just walk by this way. And once I walk here, I need to walk by this way. And my whole pattern is, and that fits into the pattern like the way I do my taxes and the way I drive my car. And it's an overall bigger pattern of this kind of stuff. Yes?
Would that be like Monk? Would he be the personality disorder or?
That's a very big, you guys watch that show, Monk?
Yes.
Police detective guy? I'm gonna say, because he's OCD about a lot of stuff, I'm gonna say he's more like OCPD.
That's what I was.
But I think, it's Hollywood, so it's really hard to tell. Right? But that's it. Now, a lot of times it's very difficult to distinguish between the two. Okay? So again, you've got to look, does this person have a whole lot of pattern? Back in the old days, when we were Freudians, the hardcore, old school Freudians like Dr. Baker would say, oh, you're really talking about this, you're really talking about somebody who has compulsive, anal retentive personality, right? And so really good examples, you watch that show, The Odd Couple. There's a new version, there's an old version, by the way, from the 60s, it's really good. The new version's pretty good. The guy from Reno 911, he's like the obsessive guy. That guy is OCPD. He's obsessive about everything. He does everything obsessively. He doesn't necessarily have like little rituals about everything, but everything is sort of painted with this idea of being obsessive with everything. That would be a good example. So if you want somebody with OCPD, go watch that. Another one that is kind of also maybe more on the autistic spectrum, but has a lot of these kind of characteristics, that's another thing you have to do is a differential diagnosis. So you all watch The Big Bang Theory? Very popular show. Sheldon. So is Sheldon OCD? Is he OCPD? Or is he autistic, on the autistic spectrum with obsessive compulsive characteristics? Really hard to figure. I mean, it's a TV character, so obviously they're writing the character to make him funny, as opposed to these other things. But this would be an example you could ask yourself.
How about Monica from Friends?
Monica from Friends, very good. Definitely OCP. I'd say OCPD.
Yeah.
Yeah, OCPD. Yeah. Not washing your hands every 5 seconds,
Yeah.
but it's definitely a little obsessive, right? And you may know people like this, right? And again, spectrum, right? Spectrum. This is how the old Freudians would have thought about this. Okay, it's a spectrum, right? I am the opposite of this. So the old Freudians would say anal expletive, not anal retentive. Right? Go to my office, looks like an episode of Hoarders. Right? That's the opposite, right? Really disorganized. My computer's organized, okay, but in my office disorganized, right? So again, this is a spectrum. It's not necessarily a disorder until it gets to some certain point where it's causing impairment. And this is very important to know about all the things we're talking about. But if you have some of these traits, it's not necessarily diagnosable. It's only when it starts bothering you, and especially for personality disorders, it starts bothering other people around you. Very important. That's a really noticeable thing about personality disorders. Yes?
Like OCD, they lie on that spectrum, where you go from someone who's a perfectionist kind of personality type. Generally, put people who are on that super end of perfectionist and you come to someone who's a perfectionist, they have a super organized desk and everything looks pretty, they have everything in its place, that kind of thing. They're probably diagnosable as OCPD, but they're completely higher. They're so well functioning that it doesn't matter because they've learned to live in that. Someone with an OCD diagnosis, one of the other distinctions is they have a hard time functioning.
Yeah. So one way you can think about it is if you have OCD, you're really a bother to yourself. If you have OCPD, you may be a bother to yourself, but I guarantee you're going to be a bother to other people. And you may be more of a bother to other people than you are yourself. Okay, like Monica is a good example of that, right? So yeah. So again, there's a lot of overlap here, but just to get the distinction out of the way. Okay, paranoid personality disorder. Marked distrust of others, including belief without reason that others are exploiting, harming, trying to deceive him or her, lack of trust, belief in others' betrayal, etc., belief in hidden meanings, unforgiven, and grudge holding. Maybe I have this one instead of little paranoia is good. We all need a little bit, right? There's a reason why we have this trait in the human population. Oh, that lion, he's so cute, looks like a big fuzzy kitty cat, I'm going to go pet him, right? You get eaten. Those people didn't survive. The ones who said, well, wait a minute, I'm not sure, I don't trust that creature over there. It's kind of cute looking, but it's got big teeth. I think I'm going to go over here behind this rock, right? We're all the descendants of the person who went over behind the rock, right? So a little bit is good. A little bit is good. gets overblown, then it becomes a problem, right? Now, here we have to distinguish between the paranoid personality disorder and the paranoid psychotic, okay? And really it's basically a matter of degree, that the paranoid psychotic is paranoid to the point of being really delusional, maybe hallucinating things, and maybe hearing voices, things like that. That's where the paranoid personality disorder is really just a lot of these characteristics sort of taken out to the extreme. But not, they could be a little bit delusional, but not quite to the point where it's, really off the chart delusional, okay? Like the delusions, or for the paranoid personality disorder, the paranoia, paranoid delusions have some basis maybe in some reality. That's where the schizophrenic, it starts getting looser and looser and looser and looser and looser. Okay? Could you have both? Theoretically possible. And you'll meet some paranoid people that kind of go in and out a little bit. I had some patients like that, in and out. One day they're just a little bit paranoid about some stuff, a little cautious. Next day they've kind of gone over into their delusion, into being completely delusional. Somebody's, there's a voice that's persecuting them, or, voice telling them that somebody's persecuting them. And they really go into the psychotic spectrum. And we'll talk a little bit about that later. Okay, schizoid personality disorder, primarily characterized by a very limited range of emotion, both in expression and experiencing indifference to social relationships. Okay. And then schizotypal personality disorder, and this is the one that really bridges between personality disorder and psychosis. And schizotypal personality disorder is really it's like a very, very mild version of schizophrenia, where you have peculiarities of thinking, odd beliefs, eccentricities of appearance, behavior, interpersonal style, and thought. It could be belief in psychic phenomena and having magical powers and things like this.
You said it was close to what?
Psychoses. This is the one that is like, if you want to think of psychoses on a spectrum, which we're now kind of doing, this may be at the very far end of the mild part of the spectrum. Okay? And then when we talk about psychosis, we'll go over some of the other ones. You think of it this way, but it's not quite to the point where it's really completely delusional. And you guys may know people like this. I have a friend, a Facebook friend, and she's a very lovely person. If you talk to her in person, you think, oh, she's just absolutely, lovely, wonderful person, yoga teacher, really brilliant, beautiful. And, she posted something on Facebook the other day, and it was starting to ranting about chemtrails. You know about these chemtrail things? That all those trails you see up in the sky are actually the government seeding us all with deadly chemicals and trying to control our minds and things like this. And somebody went on there, she did some rant, she posted some rant about this. Somebody went on there and said, that's just water vapor in the atmosphere. Well, how come it, and then she wrote back, well, how come it happens, over here but not over there? And somebody wrote back to her and said, well, that's because where she was, or that's because where the plane was in one place, it was colder, so the water vapor came out, and the other place it was warmer, so there was no water vapor you could see, right? Which is, by the way, the actual reality, okay? And she was like, well, I don't know. Well, I'm not sure. We'll have to agree to disagree. I started going, So, and then the other thing is you see, the anti-vaccine stuff, okay? Now, by the way, vaccines do have side effects. You go to get a vaccine, or you take your kid to get a vaccine, you will see, they will give you the list. Here are the potential things that will happen. Here's the people you call if there's an adverse event. Here are the things, the common adverse things, getting a headache, getting sore at the site of the vaccine, these kind of things. Here are the uncommon ones, Epstein-Barr syndrome, whatever, these severe reactions, these kind of things. They do happen. They just happen like 1 in a million or 1 in 10 million. Right? So when you go get a vaccine, it's like playing Russian roulette with a gun that's got 10 million, bullets in it, 10 million slots for a bullet, and there's only 1 bullet in there. So most of us do not, and so, by the way, the public service announcement, vaccines are tremendously important technology, because you guys are all too young to know what the pre-vaccine world was like when people were getting polio and stuck in iron lungs and things like that, and which was really, really, I posted something on Facebook the other day, an interview with the last guy alive living in an iron lung. That was eye-opening, because that stuff did happen. People got polio, they got all sorts of things. People were dying all around the world. And, we could go and talk about herd immunity, and this, for people who can't get vaccines, it's really important for other people to be vaccinated, et cetera. Yes, sometimes bad things happen with vaccines. It's very, 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 very rare. Sometimes bad things happen to people at the same time people are vaccinated, and people make a mistake. They mistake correlation for causation. And this is probably where the majority of all the vaccine complaints really lie. This is probably the majority. You get the MMR vaccine around the same time that, like, for instance, somebody would start showing symptoms of being autistic. Those happen around the same time, so it's very easy. You got to blame something because we're meaning-making creatures, and we have to make meaning out of, especially tragic events, and so we blame the vaccine. This is where you see a lot of this stuff. Okay, but again, you may find some people, some beliefs in vaccines, GMOs, etc. There's a grain of truth to these things, but then they get overblown into a kind of delusional type of thing. Yes.
Isn't autism in utero, so like it doesn't make sense to think that autism will be caused by a vaccine?
I'm not the expert on autism. That is what I have read recently. That, of course, we're now thinking that autism has to do with brain development early on. There are other people, actually, by the way, very like in the 50s and 60s, 70s, who said that same thing. So that's not a new idea, but my understanding is that idea now that's what people are saying now. Yes. Okay. And so really the vaccine, who knows? The brain is developing. And there's other theories about autism too, like it's due to viral infection. There is some evidence for that, and so it's not really clearly worked out yet. And so again, we don't really know. But I have heard that thing is talking about it being in utero, and that's the latest thing I've been reading about it. So yeah, they've gone back to an older idea. That was an idea that people talked about later on. And I had patients where you clearly, they thought, at least from the time of birth, that things happened when they were being born that they think caused the autism. For instance, giving them too much oxygen when they were being born. And that causes visual problems, and it can cause, people thought maybe some part of the brain where oxygen, too much oxygen can cause the nerves not to develop, and so there's a lot of old theories like that out there, and there's a lot of newer ones like infection and things like that. But we know now, by the way, just public service announcement, the research is overwhelmingly showing that vaccines do not cause autism. Okay? But if you go on Facebook, you start reading around the internet, you will hear much to the contrary. I'm not saying those people are all schizoaffective or schizotypal, but you start seeing people pile on these beliefs: chemtrails, vaccines, GMOs. And by the way, GMOs, first of all, everything that we eat has been genetically modified. So people who talk about anti-GMOs are being very non-specific about it. Really what they mean are transgenic GMOs. GMOs where genes have been inserted using, modern techniques of gene manipulation, right? Some of those, might be good, like putting gene for making vitamin A in rice, for people in places where they have a chronic vitamin A deficiency. That's just a thing. They have this stuff now, golden rice, very good. And then as opposed to, what Monsanto is doing, putting genes into plants so they, uptake more of the, whatever, the Roundup or whatever. That one might be a little suspect. But then to say all GMOs are bad is really, again, at a certain point when you add that on to the chemtrails and the vaccines and everything, you see somebody like that and they believe that their crystal is, powering their car or something, then you start wondering about schizotypal personality disorder. Now, I'm not saying that everybody who doesn't believe in vaccines and doesn't like vaccines, everybody who doesn't believe in GMOs or doesn't believe in chemtrails is schizotypal. I'm not saying that. I'm just saying when you start seeing a preponderance of these sorts of ideations, I would say for me personally, more than one, have to be more than one. My yoga teacher friend, I don't think she's schizotypal. That's all. I've only heard her talk about chemtrails. I don't know about the other stuff, but I start seeing more than one of these, a few of these things, then I start wondering about this. Okay? And then also, by the way, if I know they have a close relative who has been diagnosed with schizophrenia, then I really start wondering about it. I actually have a friend like that. She believes in chemtrails, she believes in all these things, You know, if you talk to her, she's a perfectly normal, functioning human being in society, wonderful person, does really good work for people, you know, is fun to hang out with, rational, you know, good person to be around. But you start asking her about her belief systems, and a bunch of these things start coming out. Slightly off, odd beliefs, slightly off. And she has a sister who is full-blown schizophrenic. That makes me wonder, right? But she doesn't bother anybody else. She is perfectly capable of running her own life. She does really quite well. Doesn't bother anybody. People literally like her quite a bit. So you would not diagnose her with this because she's not bothering herself and she's not bothering other people. Okay? So she wouldn't get diagnosed. But you could see where it could start going off the rails at some point. Okay? So this one's a very interesting one. And we're going to talk all about psychoses a little bit later on when we get to that. Okay. I'm going to let you guys have a break in a minute. Kind of had a short break in a few minutes because we had a long break at the beginning. DSM5 clusters these personality disorders into 3 clusters, A, B, and C. Eccentric personality disorders are ones where people are really weird, paranoid, schizoid, schizotypal. Cluster B, these are dramatic. There's a lot of drama going on. Antisocial, borderline, histrionic, and narcissistic. And cluster C, anxious personality disorders, avoidant, dependent, obsessive, compulsive. And these have been retained from the old DSM. And these are pretty useful. And actually what might be more useful is to actually, maybe this will come in the future, you diagnose somebody as being from one of these clusters. I would say somebody is cluster B personality disorder with predominant borderline symptomology, right? That may be a more accurate way of doing these things. And that may come up in the future. We may end up doing that sort of thing. There's a lot of overlap among the personality disorders in each of these clusters, as well as across clusters as well, too. There's some overlap. But within the clusters, a lot of overlap. And you can see this guy did a study, and he looked at this. Okay. So you see cluster A here, cluster B, cluster C, and you see the overlap here. And they were looking at abusive relationships. This guy, Aaron Soft, found that personality disorder clusters were positively correlated with abusiveness. All clusters were moderately associated with each other. It was more likely for someone to exhibit other personality disorder traits if they had a personality disorder already, which we already talked about. Cluster A and B were the most correlated with abusiveness. That makes sense. The paranoid and the emotional dysregulation kinds of cluster B stuff. In particular, a combination of jealous, suspicious, paranoid cluster A and emotionally volatile, impulsive, unpredictable cluster B behavior was found to be strongly correlated with being an abuser. Okay. After accounting for cluster A and B traits, however, the remaining completely independent cluster C traits, that's all this stuff that's not overlapping, was found to be protective against abusiveness. And that makes perfect sense, because if you're shy, introverted, avoid confrontation, avoid people, probably avoid relationships in general, you are much less likely to abuse other people. It really requires other people to be around for you to abuse them. Okay? If you avoid other people completely, then you're not likely to abuse other people. So cluster C, being this cluster C part that's not overlapping, actually is protective of being an abuser. Okay? So one good thing you can say about people in cluster C, anxious, withdrawn people, is they don't tend to abuse others because they don't want anything to do with other people. Kind of makes sense. So again, we can talk about these. Again, I'm going to go over these really quickly. Eccentric personality disorders, paranoid, schizoid, schizotypal. Again, odd, peculiar behaviors, patterns show by early adulthood, and they show up in various contexts, work, home, social situations. And here's the individual ones. We'll talk about a few of these. Paranoid personality disorder, generally suspicious, interpret the actions of others as threatening, and it can be some of the following. Suspects without sufficient basis that others are exploiting, harming, or deceiving him or her. 2, preoccupied with unjustified doubts about the loyalty or trustworthiness of friends and associates. 3, is reluctant to confide in others because unwarranted fear the information will be used against him or her. Reads hurtful or threatening messages or meanings into kind remarks or events. Is unforgiving of insults and injuries. Perceives attack on his or her character or reputation that are not apparent to others. Has recurrent suspicions without justification regarding faithfulness of spouse or sexual partner. We're going to see this last one also overlaps into some of the neurological stuff we're going to talk about. So it's kind of interesting. Schizoid person, personality disorder, detached, social relationships, indifference to social and sexual relationships, prefer to be alone, no desire to love or be loved, cold, reserved, withdrawn, insensitive to feelings of others. Okay. Season 1 and 2 Sheldon of the Big Bang probably would have been diagnosed with this, by the way, in my opinion. Now they've changed him up. They've evolved him now. He likes to be in a relationship now. Okay, schizotypal we just talked about, odd beliefs, magical thinking, strange ideas of reference, unusual perceptual experiences, hearing a voice. If somebody starts hearing a voice, then I'm starting to think they're edging over into schizophrenia. Okay, odd thinking in speech, unusual phrasing, speech which is vague, over elaborate, wanders from the main point. We're going to talk about confabulation later on in Ganser syndrome, which is also maybe some overlap with this. Excessively suspicious thinking overlaps with paranoid personality disorder, or inappropriate constricted emotions, behavior appearance that's odd, peculiar, so this can overlap with schizoid. A lack of close friends or confident overlaps with schizoid. Excessive social anxiety. Okay, so again, this is what kind of things you're looking for. This one, by the way, for me, just me personally, schizotypal personality disorder is always going to be a tentative diagnosis. Because I'm wondering this person going to become schizophrenic, or I'm wondering maybe this person's more schizoid or something else. I'm going to give them a diagnosis of this, then I'm going to wait and see. Let's recheck this in a few months. Recheck this in a year and see what's going on with the person. Dramatic personality disorders, antisocial, borderline, histrionic, intense, unstable emotions, distorted self-perceptions, behavioral impulsiveness. In other words, drama. Drama. You all have a friend. One person you know in your group, right? You got 10, 15 friends. There's one person in that group. There's always some drama around them. They never take responsibility for causing the drama themselves. It's always somebody else. Anybody have friends like this? Got that one person? Yeah. Yeah. Yeah, that might be somebody in this thing. Yes?
So you mentioned that the worse the childhood, the more extreme the personality disorder.
Yeah.
And you also mentioned that this cluster is highly associated with being an abuser. So would you say that these people probably don't see themselves as abusers, they see themselves as the victim?
Yes.
And they don't recognize that
Yes.
behavior is abusive?
When you talk to them, that's exactly what you will hear.
Okay.
Oh, they did this, they did that. It's never themselves. It's always somebody else. Now, again, there are a lot of people like that who are not going to get diagnosed with personality disorder. It has to reach a level where it's really bothering, affecting their life and affecting people around them. And again, people really severe, borderline personality disorder. You'll see that people, severe borderline personality disorder are really miserable. Other people around them may be also incredibly miserable. And if you ever do therapy with somebody who's borderline, it's really tough. That's why a lot of therapists don't work with personality disorder people. But the person with the borderline personality disorder will really be suffering. And so again, you have to make a distinction between people just sort of drama-licious, we like to say, and somebody who really has gone over full bore over and you really need to be diagnosed with. I've met some people, actually some students I've had in classes who told me they've been diagnosed with borderline personality disorder. I talked to them for 5 minutes and I knew they didn't have it. But somebody along the way diagnosed them with this because they had maybe some of these tendencies toward creating drama. But clearly they were not. And I've done therapy with borderline personality disorder, people who are severely borderline, and it's not the same thing. So again, you have to be careful because there's a lot of labeling biases here too. Oh, you come into my clinic, you've got something going on in your life, maybe it's just a situational thing, you broke up in a bad relationship and you're freaking out. You come into my clinic, oh, you're a woman, yeah, I'm going to give you borderline label, right? Which just really does a disservice for people. But that happens. That happens. I had a woman who had severe physical abuse. I won't go into details about it, and it was something that happened to her once. And she went to a therapist and was diagnosed with borderline personality disorder, and it followed her around for 10 or 15 years. And I was totally convinced. I told her, I said, you do not have borderline personality disorder. But again, you have to watch these labeling biases. It really can be a bad thing. Okay? Yes?
Is it treatable?
I could talk a lot about that. So in general, I'm going to jump the gun here.
Sorry.
In general, personality disorders are very, very, very difficult to treat.
Because the people I know that have some of
Yeah.
They just don't care.
Yeah, so those people are not gonna go into treatment.
It's your problem.
Yeah, yeah, and a lot of times, the people around the person with the personality disorder are more bothered than the person with the disorder. Okay, they're not gonna go into treatment. People do go into treatment because people really do suffer from these things. And they really wreak havoc in people's lives, it's really terrible. But what happens, the treatment is very difficult. And again, the further along you are on the spectrum of being worse, the more difficult the treatment is. And in some psychotherapists, some people make a distinction between people with personality disorders who are treatable, somewhere in the middle, maybe up to the middle of the spectrum, who can be, contained in the therapy session, who can make a contract with the therapist, act a certain way, who can try to develop some sort of insight, especially these kind of dramatic personality disorders. The people don't have a lot of self-insight. And so you can do things like mindfulness, meditation, you can do things like, full-on psychoanalysis, 5 times a week, these kind of things where you would develop a capacity for insight. You have to have some capacity for it. You got to have the muscle there in the first place, and then you can exercise. If you don't have the muscle in the first place, the exercise doesn't do you any good. And so that's kind of the question. So, somebody with a severe personality disorder may not be really treatable, or may be treatable only under really, really intense conditions. At 5 times a week, psychoanalysis for 8 to 10 years, something like that. Now there's new treatments for like borderline personality disorder. This dialectic behavior therapy, which you might go into an inpatient setting and you have a treatment team, in a very intensive way for a period of time. You may be able to treat some of these things. But they're very difficult to treat. Personality disorders in general are very difficult to treat. Okay? My dad's a psychoanalyst. He's done a lot of treatment of people with personality disorders. He's written extensively about it, and you can read his cases. The people come in, they're with him for a long time. And they actually are able to get better. It just takes a lot of time and effort, and real intensive effort, and expense too. It's expensive. Okay? You're not going to go to let me put it this way, you're not going to go to your cognitive behavioral therapist down the block, have 3 sessions, and be cured of your personality disorder. It just ain't going to happen, no matter what anybody tells you. Okay? If they're telling you that, it's a lie. You may be able to deal with some, immediate issues that are happening that might be related to your personality disorder, but you're not going to cure these disorders with that. Yes.
My friend used to date somebody who was like severe borderline. He's like also a really severe drug addict, and every little thing would set him off, and nothing was his fault. But it was like really hard because she would try to get him to see a professional. Yeah. But whenever he talked to a professional, he felt like he was being victimized. Yeah. So he would listen to them because they're clearly ganging up on him. Yeah. And on the other person's side, and it's like some conspiracy or something. Do they have medications for that if therapy doesn't work?
No, there's no medications that treat personality disorders. Okay. Medications only treat some of the corollaries of personality, like anxiety. Okay. So a lot of people with personality disorders might have severe anxiety. You can go get some Xanax or something.
Which, by the way, you got to be careful
about. Yeah. And so you got to be very careful about that, because I saw a lady for a while who was very severe borderline personality disorder, and she had like 5 prescriptions for Xanax she got from different doctors. Oh gosh. Was taking Xanax all the time. She had a lot of anxiety, and she was probably addicted to the Xanax. Xanax is very addicting, by the way. It's a very, very bad withdrawal. And she also drank. She had, alcoholism to some degree, and so, very, very. There aren't good drugs to treat this stuff. Okay. Yes.
Just wondering, you're saying when you talk to people with false diagnosis, who come to you, in the reverse of that, when you talk to people who do actually have borderline personality disorder, how do you? Is it as easy to tell?
Yeah. Very easy.
It's like, what would be some of the in real world settings?
Well, in the real world, just from my experience, there may be other things, and other psychologists might tell you something else. In the real world, from my experience, the trigger for me, the thing that really triggered for me the thought that this person may have some kind of personality, especially borderline personality disorder, was like inappropriate disclosure. I would see somebody for one session, they come in for an initial session, and they would immediately start telling me things that, a normal person would really wait till they knew me and really trusted me before they would disclose. Really intimate details about sexual life, about the abuse they'd been through, all sorts of stuff. That was always a red flag for me. You know, that will say, oh, I really wonder about this person now, something going on here, personality disorder wise. And then the other thing that you really see that's other typical is, we call this a splitting defense, where the person really, really goes hot and cold very quickly. You know, so one minute you're their best friend, they love you, you know, oh, you're the best therapist, if you're doing therapy, you're the best therapist in the world, you're really helping me, you're so great, I've only seen you for 2 sessions, you know, oh, really? And then they come in the next week and you're absolutely shit, you're the most horrible person, you're the worst therapist, they're gonna sue you, they're gonna do all this stuff. Well, last week you told me how great I was. No, I didn't, right? Oh, that's, you know, real red flag, this splitting back and forth between bad and good. That's another real overt symptom of people with borderline personality disorder. Now, everybody does a little splitting, right? But if I do it, I'm aware of it. Oh yeah, yesterday I was really in a bad mood. I was cranky at people. I had to go apologize to my wife afterward, because I was so cranky, you know, there were no coffee, Starbucks was closed, you know, okay, oh God, I was such a horrible person yesterday, right? Someone with borderline personality, severe borderline personality disorder won't realize, they won't even have a sense that they did that. They won't be able to recognize that. That's another real big warning sign. Okay? So as a therapist, those are the kind of things that you would see. And by the way, you know, if I'm a therapist and I'm not trained and I don't have experience working with people with personality disorder, you really need to refer people out, because most therapists don't have training, enough real training to work with people with personality disorders. And you find somebody who's a specialist. So we had a guy who used to teach for us, Dr. Hamer, teaches at Northridge, and he's a good friend of mine, great guy, and he has a practice, he only sees people with personality disorders. That's his thing. And my supervisor, my clinical supervisor, typically saw people with personality disorders and actually worked with people with psychoses too, and that was his specialty. And you got to find somebody who specializes. And it's just like a doctor. I go to a doctor and I got a cough. You know, I go to my GP. If they look at my lungs and they say I have lung cancer, I better go to the cancer doctor, right? I don't just hang out with the GP anymore. There's something more serious wrong, you better go to the specialist, right? It's the same thing in psychotherapy. Unfortunately, psychotherapists don't necessarily adhere to that all the time, and they end up seeing somebody with a personality disorder and they get in over their head. And sometimes they can do more harm than good. So it's very, very, very important to be able to figure these things out and to send somebody to somebody who can actually help them. They're not easy to do therapy with. Therapy can, some people, if they're not completely over the top, therapy can help them. And it's just that therapy is probably going to be more intensive and take more time. Okay? You know, it's really, I think, my personal belief is psychotherapy, especially intensive psychodynamic therapy, psychoanalytic therapy, is probably the best treatment for this stuff. That's I mean, we have this new DBT thing now, and I think that also, you know, has some promise. We'll see how that works out. But again, you know, the amount of effort, intense effort, and the amount by the person, the amount of expense and time to put into, you know, working on personality disorders is pretty daunting. Okay? So this is one of the least understood, well worked out areas of especially clinical psychology. So, you know, maybe one of you guys will go to grad school, get a PhD or PsyD, and then figure out a better treatment. That would be awesome. You know, a good topic to study for your dissertation. So, you know, encourage you guys to go out and do that. Okay. All right. Yes. Question. Okay. So we had antisocial personality disorder. We'll go to the next cluster. Again, here are some of the things. This is antisocial personality disorder gets diagnosed after the age of 15. For kids, there's sort of precursor disorders, oppositional defiant disorders, conduct disorder, things that might think this person's going to end up being a psychopath. But you diagnose antisocial personality disorder, psychopathy, after the age of 15, and you would these are the things: repeated acts that are ground for arrest, criminal acts, deceitfulness, repeated lying, etc., impulsiveness, failure to plan ahead, irritability, aggressiveness, repeated physical fights or assaults, reckless disregard for the safety of others, consistent irresponsibility, lack of remorse, rationalizing having been hurt, mistreated, or stolen from another. They need to be at least, well, this says since age 15, but usually they get diagnosed from, they have to be 18, okay? Et cetera, et cetera, et cetera, okay? And you got to make sure this is not part of mania in a schizoaffective disorder or bipolar or something like that. I have a lot more to say about antisocial personality disorder. I will try to work more into the course as we go along. Okay? My other Nazi Germany class, I showed you guys brain pictures the other day. I don't know if I have those on here. All right, just talked about borderline personality disorder. Can be real or imagined abandonment, pattern of intense unstable relationships, devaluation of other people, the splitting thing, idealization and devaluation, identity disturbance, impulsiveness in 2 areas that are potentially harmful: spending, sex, substance abuse, reckless driving, binge eating, etc. Repeated suicidal behavior or threats, self-inflicted cuts or burns. We're going to talk about self-mutilating behavior later. Significant changes in mood or observable emotion, chronic feelings of emptiness, also easily bored, inappropriate intense anger or differently controlling anger, temporary stress-related psychosis. Okay, so this is the one area in personality disorders where somebody can have temporary overt psychotic symptoms. This woman I was telling you about, who I saw when I was terminating therapy with her, she actually went right in front of me into a complete psychotic breakdown. And I said, I think maybe I need to take you to the hospital. And she pulled herself out of it and said, oh no, I'm not going to the hospital, because she was paranoid of all the hospitals and doctors. Pulled herself out of the psychotic break so I wouldn't take her to the hospital. It was like an amazing thing to see. She wasn't faking it. It was real. It was just like, whoa. We're going to talk about demonic possession. You see these kind of things that just seem inexplicable. And that was something I saw personally. It was just like, wow. But this is also something that's seen among people with severe borderline personality disorder. They may descend into psychosis temporarily. Yes?
Isn't guilt also a huge part of borderline personality disorder?
Guilt can be part of it. Yeah, it can be part of it. I mean, it can be part of that emotional, the changes in mood, periodic sadness. Sadness is also very common. It could be guilt and anxiety, sadness, any of those, anger. Yeah. Yes?
The person I knew who had this also had a narcissistic personality disorder. Is it often that they...
Huge overlap.
Okay.
Huge amount of overlap. Just, really sometimes hard to distinguish. If I go into a therapist or psychiatrist to get diagnosed as a male, narcissist or antisocial personality disorder. If you go in as a female, borderline. There's labeling biases, real problem. Okay, a real problem with labeling biases. Yes?
So there's an overlap with the 3 different clusters. I was wondering if you can have be comorbid with some of these personality disorders that lead to antagonistic in their symptoms.
Yes. You can have weird mixtures of symptoms, yes. You could have borderline personality disorder, for instance, and also be incredibly dependent. But then you're dependent on somebody that you're constantly arguing with them and getting in fights. That's, definitely something you see. Right, so yes, you can have, it's really mixed up here. This is a really difficult area because everything is so mixed up. It's really hard to tease out these fine distinctions between many of these things. Yes?
So that basically means that, you wouldn't diagnose them?
It's important to diagnose them. For me, again, I'll just give you my view on this. It's important to diagnose these things, but it's important to remain flexible. And then as you get to know the person over time, maybe you can hone in a little bit better on what's going to be useful for them. But in general, if somebody comes in, they got one of these personality disorders, I want to get to know them really better. I'm going to be basically thinking that I'm going to be doing really long-term therapy with them. And so in some sense, if somebody's coming in, they're getting long-term therapy, the diagnosis is not going to be that helpful. What's going to be helpful for me is understand their individual specific dynamics so I can be a good therapist for them. Right? And it's going to take a long time. Yes?
So because you could diagnose something in the beginning and then you could have long-term therapy with them, and then say after a year or 2,
Yeah.
you may not feel like you have that diagnosis.
Yeah, I might revise my diagnosis. Yeah. And at some point they might get better. Sometime and they might get better. They might be, okay, now you're better, or at least well enough to go out and keep it together on your own. That's also possible. Yeah, absolutely. Yeah. The problem is when you go to like an inpatient place or whatever, or a facility, you get these diagnoses, it can stick with you, especially if you're billing insurance for your treatment. And these can be very stigmatizing diagnoses, right? You get a diagnosis of this and you're going for employment, somebody finds out you have a personality disorder diagnosis, you may not get hired. Okay, so these are kind of things. I be honest, my feeling is, again, I'm not your average, I wouldn't be your average psychotherapist. I would avoid diagnosing people if possible, especially with this kind of thing. I mean, the diagnosis would be useful for me as a therapist, not useful to make as official thing, unless I had to do it for insurance purposes or something, or they were in the hospital and I needed to give them a diagnosis. I would try to avoid in general, I try to avoid labeling people. Okay? That's just me. You know, but you find in most psychologists, that's not necessarily the case. Yes?
Can these personalities disorders be severe enough to cause hospitalization?
Yes. Oh, often. Very often. Yeah. In fact, there's some large percentage of people who show up in the ER have personality disorder, especially borderline. Because borderline people try to commit suicide quite a bit. Yeah. So yes, absolutely. You nurses? Yeah. You've seen these guys in the middle of the night coming in.
Yeah, we have now, especially because of the decrease in our mental facilities,
Right.
especially since Vista Del Mar burnt down.
Right.
It's, we have to keep them, and we
Yeah.
sometimes we have to hold them in the ER for up to 3 days if you're on a
Yep.
12-50 hold.
Yep, and it's very expensive, and it's not going to necessarily cure them.
No, it's not.
You know, I mean, I'm sure you're giving them great care, but yeah, it's really sad. You know, I mean, this is one of the problems. I mean, this is, you talk about people who fall through the cracks. You know, we're going to talk about psychosis next week, and we're going to, yes, people fall through the cracks all the time. Just go and walk around in downtown Ventura, you'll see that. But also people with personality disorders fall between the cracks. And because we don't have good treatments. You know, psychiatry can do nothing for these people. There's really no good drugs other than just some temporary, you know, amelioration of the symptoms. And, you know, psychotherapy, you know, long-term intensive psychotherapy, insurance won't pay for it. And so unless somebody can afford, you know, to go in and see somebody 5 times a week or go put themselves in a facility where they're going to get DBT, you know, treatment, there really is no real good treatment for these guys. So they just get lost in the cracks and they just wander around and suffer. You know, it's really sad, right? And again, it's something, you know, we could probably do a better job with, in my opinion. Yes?
Because we don't even have access to psychiatry or psychology.
Yeah.
or ED. It's
Yeah.
just if we're lucky, we get a crisis team, and sometimes that's
Yeah.
over a day to get.
Yeah, one of my former students now is a psychologist, PsyD, and he's working at VCMC there, and they love having him there. And he's there available, you know, he's there and he's available to do, you know, psychotherapy with people when they show up. And, you know, he's not doing long-term psychotherapy, but he's there. Psychiatrists, I work at CMH, and they can't even find any psychiatrists to hire. They can't find a full-time psychiatrist to hire because there aren't enough of them. Because I don't know if I told you guys, there was another class, but people aren't going into psychiatry anymore. It's kind of a dying profession. And so, you know, and psychologists have not yet, in California, got prescription privileges to take up the slack. And so that's actually a thing that always is coming, you know, around, that psychologists are trying to get prescription privileges. They're getting them in a number of states now. But there's a shortage of people who can prescribe, who can do what psychiatrists do, prescribing drugs for people with mental illnesses. So a huge shortage. There's nurse practitioners can do some, and psychiatrists. And what happens is most of the psychiatric drugs are prescribed by general practitioners who have very, very little training in psychological illness, mental illness. I mean, you know, laughably, they get a rotation in medical school for a couple months, and that's it. And so it's really, really. You know, not a good situation. However, there are now a number of states, and in fact, Illinois just became the last state to allow psychologists to have prescription privileges. And I think what's going to happen is you'll see, those of you thinking of going into clinical psychology, you'll probably at some point have an option to become a prescribing psychologist. There's good and bad things about that. I'm not going to go into detail about that. We can have a debate about that. There's good and bad things about that, but certainly the lack of psychiatrists is a huge problem that the medical community is not addressing whatsoever. They don't like psychiatrists for the most part, so they don't care if it dies out. But they also don't want psychologists to get prescription privileges. So it's this weird, odd thing that just basically means that people with severe mental illnesses don't get services. And it's ongoing, and it's sort of crisis level now. I mean, it's really bad. Yes?
At my mental health place that I go to in LA, there's only like one psychiatrist that I know that works here, one or two, and the one that I have is like in such high demand, they had to like put all these extra regulations on him. So like,
yeah, it's terrible.
Yeah.
When I worked at the sister mental hospital, this one in San Jose, which we had over 1,000 patients in the hospital, the psychiatrist came once every, we were lucky, once. For a while he was coming every 2 weeks, and then he was coming like every month, and then he was coming every like month and a half, every like 6 weeks. He would come in and he would see patients for a total of 5 to 10 minutes each, and then and that would be it. And so, you know, I mean, the amount of, so what ended up happening is that on my ward, the general practitioner, MD, and myself, we were the ones who came up with what drugs we thought. I would do the research, and she would prescribe the drugs, and then we'd go to the psychiatrist, you know, try to get in to see him. We weren't always able to get in to see him. Try to get in to see him, and then get him to sign off on what we did, and then we'd give the person the drugs. It was incredibly difficult, and that was like, you know, 20 years ago, you know, and it's much worse now. So I mean, it is really kind of a crisis situation. What you find is that people then go self-medicate. So you wonder why people with personality disorders are taking so many drugs. People with borderline have drug problems because they're self-medicating, you know. And, you know, I mean, it's not always bad to self-medicate, but, you know, if you're self-medicating with hard drugs, then it really becomes an issue, you know. Somebody wants to do a good doctoral dissertation, you could study to see if people are going to self-medicate with cannabis more now. It'd be a very interesting thing to see what happens with it. I could give you a whole lecture about cannabis, but we're not going to go into that today. So, because cannabis, there's good, bad, and indifferent about cannabis. For you guys at your age, most of you, it's still going to be a little bit in the bad phase. Once you're a little older, it gets into the indifferent phase, and once you're my age, it's actually good. Not that I use cannabis, but yeah, we could talk about that. That's a whole other thing. So yes, all these problems, I'm glad you guys, these are very good questions, by the way, and I think they're good to bring up and good to realize about this. Okay, we're going to really run out of time now. I didn't give you guys a break, I'm sorry. If you need a break, take a break, come back, we'll just keep going, and, you know, sorry about that. Beginning in early adulthood, individual histrionic personality disorder, excessional emotionality, discomfort in situations where he or she is not the center of attention. This would be also big overlap with narcissism.
We were trying to figure out the word of when a person with a personality or any type of is not aware that they have a personality disorder, but feels like it's not a big deal. The word is, what was that?
Did you get a good word?
Yeah.
What is it?
Egosyntonic?
Egosyntonic, yes, very good. Oh, you guys are really good. Egosyntonic, where something just seems like that's just, you know, it perfectly, you know, it is in line with, you know, the way your ego is viewing the world and interacting with the world. It sort of fits along with that. Okay, so you don't see how you are manifesting as opposed to the opposite, which is ego dystonic.
Yeah.
So most of you guys, if you're acting really strange, most of you will go, oh yeah, I'm really weird at it. It's really not me. That's not me. I wasn't myself, right? Right? Anybody go to a party, drink a little too much, and the next day your friends are telling you how you behaved, and you're going, that's not me. I would never do that, right? That's ego dystonic, right? But ego syntonic is where you don't really realize because that's just, you know, how you are, right? So personality disorder traits, a lot of times for the person are very ego syntonic, okay? And part of this also can be a lack of ability to reflect on things, to reflect on yourself, especially with borderline personality disorder. People have identity issues, but also narcissism, have identity issues. They have a difficult time reflecting on themselves. Very interesting. Okay, histrionic personality disorder. You live near LA, so you see this all the time. Discomforts in situations where he or she is not the center of attention. Big overlap here with narcissism. Frequent inappropriate seductive or provocative behavior in interpersonal interactions. Rapid shifts in emotions. You know, that overlaps with borderline. Consistent use of physical appearance to draw attention to the self. We don't have any of that in Los Angeles. Excessive dramatic style of speech that lacks detail. Opinions are strongly presented, but underlying reasons may be vague. Self-dramatic, theatrical, exaggerated expression of emotion. Easily influenced by others. And that one's got that's crosses over with dependent personality disorder. Views relationships as more intimate than they actually are. Overvalues relationships. Okay. And this is a histrionic person. Again, a lot of overlap with other things here, narcissism and other personality disorders. Narcissism, we're going to talk all about this in detail. Person has a grandiose views of themselves, lack of empathy that begins in early adulthood, present in various situations, very demanding in their relationships, pattern indicated by 5 or more of the following: inflated sense of self-importance, exaggerates achievement, talents, expects to be recognized as superior without corresponding achievements, is overly concerned with fantasies of unlimited success, power, brilliance, beauty, or ideal love, believes that he or she is special and unique and can only be understood or should only associate with other special high-status people or institutions, requires excessive admiration, has a sense of entitlement, takes advantage of others to achieve his or her own ends, lacks empathy, is often jealous of others, shows arrogant or domineering behaviors or attitudes, et cetera, et cetera, et cetera. We've gone into some detail about this. This is narcissistic personality disorder, and what I want to do later on is talk to you a little bit about healthy narcissism, what I call neurotic or compensatory narcissism, then neurotic personality disorder, and then the bad variant of this, what we call malignant narcissism. So I really look at narcissism as 4 things. I'm going to go into some detail about this later on. Narcissism is really interesting. We're really fascinated by this now. We have leaders in this country who many of us have, even publicly, diagnosed as having narcissistic personality disorder. And I'm going to say this already, and again, I hope you take this the right way. I'm not pronouncing political things. I truly not try to be political in my classes. My feeling about politics is that my job is to teach you to think for yourself and to make your own decisions about political things. So if I seem like I'm picking on any individual, I am not. I am just basically observing psychological phenomena out there in the world, and whatever my opinions about the person psychologically don't have anything to do necessarily with their politics. Okay? I don't know they're doing political things. And in fact, it's very difficult, speaking of narcissism, to find people in political power in this country and around the world who don't have some degree of narcissism. Because it's, in this country, it's actually a job requirement. You can't be, I'm not saying that people necessarily have narcissistic personality disorder, but I would maybe maintain that most of the political leaders that we have at least some sort of neurotic or compensatory narcissism going on. Yes?
Do you feel like some of that is just for show?
And some of it is for show, but it's very difficult to tease out because narcissists like to show off. So they like to get admiration, and so they would do things for show from a narcissistic way. And some of it is just to show that we're strong, to show everybody I'm strong so they'll elect me. And so there's some of that. But there's really hard to tell.
But then there's some that are like introverts, and then they go into the public eye, do that, and then they go back home and they're...
Yes. Yeah. There's some, and again, this sort of, and I'll talk to you about compensatory narcissism. People with compensatory narcissism, if I were to check half of you guys in this room, 3/4 of us in the room, myself included, we would have some degree of compensatory narcissism. It's not necessarily abnormal. Okay, and I'll give you some examples of that later on. Okay? But we could also look at leaders, we could say there are leaders that clearly have narcissistic personality disorder, and there are leaders that clearly have malignant narcissism. Okay? And I gave you already some ones I thought, malignant narcissism I might have some strong suspicions about. Hitler is a good one. Those of you in the Nazi Germany class, to give away the punchline, I'll talk about Hitler and malignant narcissism. I think he was a malignant narcissist. I think he fits perfectly. And I'll talk about some other leaders as well. We can talk about people. And so I just want to go on record here because, I don't want to offend anybody who likes Donald Trump. That's perfectly okay if you like Donald Trump. That's great. But I will tell you that he's somebody I've been lecturing on for the past at least 10 years when I give my lecture on narcissistic personality disorder, well before he ever became running for political office. And I don't feel like I need to change my lecture just because he became president. Okay? And I've gone on radio and I've said this on public radio, and where I said, no, I do think he has narcissistic personality disorder. I think most mental health professionals would make that diagnosis. Even though there's some debate whether we should be doing that from afar. So I think it's a specious argument that the psychiatrists put on themselves. I'm a psychologist, so I don't care. It's perfectly possible to, especially when people are in the public eye and you're seeing a lot of behavior, the behavior is very consistent over time. I think it's fairly easy to make a reasonable diagnosis of people. So I'll talk in more detail about that. Okay? But I don't want to offend anybody. If you like Trump or you like Trump's policies or whatever, hey, have at it. That's on you. Whatever your political beliefs are, that's great. but we're going to talk about psychology, we'll talk about narcissists, and so we'll talk about some people in the public eye. He's not the only one, by the way. You know, I could make the same claim of other political leaders from, you know, opposite, on the opposite political spectrum. We could talk about that too, and maybe we'll do a little bit of that. Okay, anxious personality disorders, avoidant, dependent, obsessive. These guys appear anxious or fearful. Avoidant personality, socially inhibited, feels inadequate, oversensitive to criticism, avoids work-related activities that involve social contact, unwilling to get involved with people unless they're certain of being liked, fears of shame and ridicule lead to excessive shyness with intimate relationships. We're going to see some culture-bound disorders that fit this very well, by the way. It's overly concerned with criticism, rejection in social situations, inhibited in new social situations because of feelings of inadequacy, views self as socially incompetent, personally unappealing or inferior, unusually reluctant to take personal risks or do new activities because of fear of embarrassment. These guys don't often go in for treatment. Okay? Everybody in this cluster, they tend to avoid treatment. So you're not going to see a lot of these guys if you become a therapist. They won't show up in the ER unless there's something probably physically wrong with them. Then they'll show up. And they'll get the hell out of there as soon as they can. Dependent personality, we talked about this. Difficulty making daily decisions. Needs others to assume responsibility for major areas in their life. Difficulty voicing disagreements. Difficulty starting projects or doing things on their own. Excessively attempt to obtain support from others. Feels uncomfortable or helpless when alone. Urgently seeks another relationship with support when one relationship ends. And this is how I distinguish between the person with the personality disorder and the person who does this sort of situationally. Okay? If they immediately need to go into another dependent relationship, then I start wondering about this. Overly worried about being left to take care of him or herself. Obsessive compulsive personality disorder, we talked about this already. Overly concerned with details, rules, lists, organizations, order, schedules. Unable to complete a project because his or her own overly strictly standards are not met, and this is sometimes why people go into therapy, because they're having work problems because of this. They're so overly obsessive they can't get work done. Excessive emphasis on work and productivity, such that leisure activities and friendships are devalued. And you see this a lot in people who are workaholics. Overly conscious and inflexible about issues involving morality, ethics, or values. Anybody see the Doctor Strange movie? By the way, my favorite Marvel character of all time is Doctor Strange. Totally awesome. But remember at the end of the movie, those of you guys who saw it, his guy who hangs out with the ancient one, Mordo. Mordo is obsessive compulsive personality disorder. He's inflexible. His morality is inflexible. You can't borrow from the bad guy in the other dimension. That's absolutely not. So he actually goes off on his own. That means we're going to have sequels, thank God. Awesome. But also means that guy had is a little bit like this, okay? A little bit like this. And flexible morality. And unable to throw out worn out or worthless objects despite lack of emotional value. We're going to talk about hoarders in a few weeks. So we'll see this crosses over with hoarding. Reluctant to delegate tasks or work to others. We find this in the work situation. Another reason why people are referred for therapy, because in work they cannot delegate their work, because nobody can do it as good as they can do it. And so they end up taking on the work, and it ends up not being very good, and then they get in trouble, and then they go to HR, and HR says you need to go to the therapist. Adopts a stingy spending style toward both self and others. Money is seen as something to be gathered for future catastrophes. People can have an obsession about money. Again, this is the old Freudian view of anal retentive personality. Money is a whole thing in Freudian psychology about money. It's really quite fascinating. Wish we had time to go into it, but we don't. Happy to talk to you about that if you're interested. And rigidity and stubbornness. Okay, also, by the way, we also have the DSM-5 personality disorder trait not specified. Sorry, that should say not specified. Right? We don't know what it is. So we have a wiggle diagnosis. We know they seem to have a personality disorder. We're not quite sure what it is, so we'll give them this tentative diagnosis, then we'll see what happens. Okay, so there's actually a diagnosis for that. Now, traits that are common in all personality disorders: self-centeredness, lack of individual accountability, lack of perspective taking and empathy, manipulative exploitive behavior, vulnerability to other mental disorders, distorted or superficial understanding of self and others' perceptions, socially maladaptive, and no hallucinations, delusions, or overt thought disorders except for brief psychotic episodes in borderline personality disorder and maybe in schizotypal personality disorder. Okay? 'Cause they're talking about hearing voices and stuff. To me, that's now you've gone into the schizophrenia realm. But typically, none of these things are really overt things. Okay? So these are, and I want you to keep these in common because these will also be things, traits that we will see in many of the things that we're going to talk about this semester. For instance, when I talk about vampirism and people who think of themselves as vampires, you're going to see a lot of these things come up. Okay? Okay. I've got time to go into this right now. You can look at this. It's an interesting article, but I don't want to go into it now. Oh, maybe I should. Here's an article, Clarifying Association Between Psychopathy Facets and Personality Disorders Among Offenders, and this is basically saying the same thing I talked to you already about when we talked about psychopathy, that we really can think about psychopathy sort of in a spectrum to some degree. Okay. Now, imagine a party where everybody had personality disorders. Kind of do a little informal quiz here. Not a real quiz, but just look at these things. Okay, call her Donna. She danced into a party, immediately became the center of attention, sweeping gestures of her arms, dramatic displays of emotion, boasted about her career as an actress in a local theater group. During a private conversation, a friend inquired her about the rumors she was having some difficulty in her marriage. In an outburst of anger, she denied any problems and claimed that her marriage was wonderful and charming as ever. Shortly thereafter, while drinking her second martini, she fainted and had to be taken home.
Well, the problem is 2 martinis makes her faint.
Well, it could be. What do you think personality disorder-wise? What? Histrionic. What else? Could be narcissistic. What else? What? Or it could be borderline, yeah. You need a little more information. Yeah. So already you're getting the sense that making the diagnosis is a little difficult here. By the way, this is, you know who this is, right, in real life? Courtney Love. You guys know about Courtney Love?
Yes.
Brilliant, intellectually, incredibly smart woman, by the way. Incredibly smart woman. I have some suspicions that she might be diagnosable as having borderline personality disorder. She seems to, that splitting thing I told you about, instability of identity, yeah, she seems to have that sometimes. I don't know that much about her, but what little I've studied of her, I can see a little bit about that. I do admire her. I think, artistically I admire her. I don't buy into the fact that, she had Kurt Cobain killed. That's one of the rumors, about that, right? She had him killed, and, I don't buy into that, but that's, that's like chemtrails for me. But definitely there's some interesting person. Well, speaking of Kurt Cobain, we'll call him William. William wandered in the party but didn't stay long. The negative forces of the room were unsettling to his psychic soul spot. The few guests he spoke to felt somewhat uneasy being with this aloof space cadet. What would you diagnose him as? Schizotypal. What else? Schizoid. What else? What?
Maybe paranoid.
Well, maybe paranoid. Negative forces, maybe paranoid. Yeah. Now, in real life, Kurt Cobain, what do you think he suffered from? Depression. Yeah. Depression exacerbated by severe somatic complaints. He had a lot of stomach pain, untreated stomach pain, which he self-medicated with heroin, which is not a great thing. Could he have had a personality disorder? It's possible. It's possible he could have had something. Again, when we start seeing intense somatic things, then we start wondering what's going on with the person. He's a guy, in my opinion, who could have really, a really good psychotherapist could have really helped him, I think. And I think it's a shame that he didn't get the help that he needed. It's really too bad. But brilliantly talented guy, absolutely. I know you guys may be too young. I don't know. You guys listen to Nirvana still?
Yes.
You listen to the Foo Fighters, right?
Yeah.
Dave Grohl, So yeah, but brilliantly talented guy. Just died way too soon. All right, now we're going to one of my favorite subjects. This is so good. This show is like God's gift to psychologists. We'll call the girl Nicole. She paraded into a party drunk and continued to drink throughout the night, laughing and giggling. She flirted and danced with many of the men and started to make out with 2 of them. Twice during the evening, she disappeared for almost a half an hour each time with a different man. After a violent argument with one of them, she was punched in the face and had to be taken home. Once home, her friends tried to console her, but she was too worried about her looks to calm down. This is actually pretty much verbatim from an episode of Jersey Shore. It's like, oh my God. But there was a year when that show was actually first came out, the first season, I actually required my students in this class to watch it. Everything we talked about, almost everything we're going to talk about in here, you could see some aspect of Jersey Shore. What would you diagnose Nicole, otherwise known as Snooki? What would you diagnose her with? Histrionic. What else? Narcissistic. What else? Borderline. What else? Dependent personality disorder. She was very dependent personality disorder. Yeah, very, very interesting. Just brilliant show. I mean, you can't, as psychologists, we couldn't ethically set up a psych experiment to observe these kind of behaviors, but reality TV producers can do this kind of stuff. So, now, there's JWoww. She was the normal one. She seemed fairly normal. And then there was, what was the other girl's name? Sammy. So
She's dependent.
Sammy, dependent personality disorder, maybe some other stuff going on as well, but they edited that a lot to make her seem really, really pathological. Her boyfriend, by the way, who was, what's the big, Ronnie? What do you diagnose Ronnie as?
Steroids.
Yes, you got it. Steroid-induced anger issues. Yes, absolutely. I don't think, you guys who are bodybuilders, you correct me, I don't think you get that rip without steroids, unless you're just like training for the Olympics or something. I don't think you get that rip through gym, tan, and laundry without steroids. And I think one of them might have admitted to doing steroids, maybe. Maybe it was a situation might have admitted to doing steroids. So, it's just, by the way, well, here we go. Next slide. We'll call him Mike. He spends most of the day going to the gym. He's fond of bragging about his six-pack abs. Now all the women want him. People seem to be bored around him, but he keeps right on talking. When he made a critical remark about the weight of one of his women friends and hurt her feelings, he could not apologize for his obvious blunder. He tried to talk his way around it and even seemed to be blaming her for being upset. Narcissistic. And there it is, Mike the situation. There he is. Well, you all know he is now a multi-millionaire.
What?
Yeah. Multi-millionaire.
One of them has a food truck.
Yes. Yes, multi-millionaire. You want to know why? It's really quite interesting.
Because people like to watch this?
No, because the show was first done on MTV. And MTV usually has some kind of thing, you go on MTV where you can't, you cannot go out and do like, do commercials and stuff like that because you are, on their show, right? The contract. The show got picked up for a second season. I can't remember if it was MTV or somebody else picked it up. But somebody, whoever did the contract the second time around, forgot to put that clause in the contract. So they could actually go out and start doing ads and everything. You saw Mike the Situation was doing ads for weight loss stuff and everything. Apparently he was pulling in about $4 million a year from those. And so now is a multi-millionaire. I mean, he may have spent all the money by now. And I think actually most of them now, because of that, what was his name?
Pauly D.
Pauly D got another show. And then Ronnie, you don't know what happened to him. Took him back to the zoo or something. What's that?
I said that Mike's potentially going to jail for like 20 years for like tax.
Really?
Yeah.
Oh, that's okay. Well, there you go. So anyway,
It's another narcissistic maneuver right there.
It's not a very bright movement.
No, but it's good. It's a narcissistic thing to say that money's mine and
I'm special and I don't have to pay taxes like everybody else. Yeah. The other guy who did that was the actor Wesley Snipes, who, by the way, the first two Blade movies were really good. The third one was kind of crappy. The first two are really good because he actually wanted to he thought he could direct the third one. He got involved in directing it and he made people, and so it tanked. But he also got in trouble with the IRS. Don't mess with the IRS. Yeah, very narcissistic thing.
Do you think it's it's obviously more prevalent in males and females, the narcissistic?
Narcissism, yes.
Why is that?
It is diagnosed, I believe, more in males, but I think narcissism is you find it in males and females. We can find plenty of females who are narcissistic. I'm picking on the guys. I'm picking on the guys in this class. We can find there's labeling bias as well. If you're female and you're narcissistic, you might be more likely to be diagnosed as borderline, right? But there's a lot of overlap. Okay, this gentleman who you may have seen. Again, I'm not picking on anybody politically. We know this guy has a political bent to things. I'm not picking on him politically, but I'm just talking about him as his personality. You guys know who this is? Bill O'Reilly. What do you think? Do I even need to mention anything?
Narcissism personality.
Yeah, narcissism. What else might he be?
Antisocial.
Yes, good. What else?
Paranoid.
Paranoid, yeah, possibly. Though I do know somebody who knows him, and what she tells me is that actually his political views and views on things are actually really exaggerating his TV personality. Not the narcissism, by the way, but the other stuff is. Well, you guys seen these video clips? I like to show these. Again, I'm sorry if anybody's a Bill O'Reilly fan. I apologize. So, anybody here Bill O'Reilly fan? I don't want to. All right. Well, I don't want to show. I won't show the clips. You don't care. But he's a guy. I think. Again, I don't know him personally. I don't know enough about him, but I think he comes off as narcissistic a little bit. Okay. I can pick on him. Again, he's not the only one, and I can pick. I'm sure I could. You know what I really should do is next time I'll pick somebody from the opposite political spectrum, because we can find lots of people who are, you know, opposite of him politically who would fit the same bill.
Bill Clinton fits pretty solidly.
Bill Clinton, definitely. Bill, Hillary, Barack Obama can all find some level of narcissism in them. Whether you're going to say they're narcissistic personality disorder or compensatory narcissist, I would maintain that Clinton is probably compensatory narcissist. Different, a little different. But on the compensatory narcissist level, I would say he's pretty far along.
Well, I think it goes hand in hand with egos, with politicians and egos.
Yeah. And ego, by the way, that's a good portion. Having a big ego is not necessarily comorbid with narcissism. You can have a big ego and not have narcissistic personality disorder. In other words, if you have a big ego and know you have a big ego, then and by the way, Bill O'Reilly, because I know somebody who knows him, he also may be not narcissistic personality disorder. He may be the compensatory narcissist because he knows he has a big ego. Again, my friend knows him. You know, he will talk about. Yeah, I know I have a big ego. He's aware of it. Right, somebody with NPD, narcissistic personality disorder, may not be so aware unless they've been through a lot of therapy. Okay, so I'll give Bill a pass. He's got enough trouble for other stuff now that we'll leave him alone. All right, we call him Sheldon. He arrives at the party exactly on time. Makes the point of speaking to every guest for 5 minutes exactly. Talks mostly about technology and finance, avoids any inquiries about his feeling or personal life, leaves precisely at 10 p.m. because he has work to do at home. OCD. This is early season Sheldon, not late season Sheldon. What else? OCD, what else?
OCPD.
Paranoia maybe? OCPD, yeah, OCPD. Avoidant. Yeah. Schizoid, possibly. We don't know. Not antisocial. He's not manipulating or hurting people.
Well, I mean, just kind of like limiting the amount of interaction.
Yeah, antisocial personality disorder people can be very charming and don't limit their interactions. They want something from you. So a lot of them are very, very charming. Psychopaths can be very charming.
Yes.
Okay, treatment. We talked a little about this. First of all, Otto Kernberg is a psychoanalyst who's written extensively about treatment of antisocial personality disorder. Long-term intensive psychotherapy. Okay, mostly talking about borderline personality disorder, but again, this overlaps with other personality disorders. And of course, we also have now DBT, cognitive behavioral therapy. I'm not sure, it's not a long-term real therapy. I'm not sure it would be too effective with personality disorders other than to deal with specific aspects that are problematic, but really for long-term treatment, you would do dialectic behavior therapy, which is a combination of CBT and mindfulness training. And again, you can put a little bit here about this. Treatment of, there is some studies of treatment of paranoid personality disorder with CBT. However, with CBT, the problem for me with CBT is that it is now, if you're a CBT, if you join the cult of CBT, you will now say CBT is good for everything because that's what the research shows. Most of the research is very short-term, and it's only dealing with some specific things. And so again, for long-term treatment, we really have no idea. But it is being used now. They're trying to use it for personality disorders. My understanding is that these studies that support this are very short-term. They're not following people up in a year or 5 years to see how people are doing. Okay. In general, none of these therapies, no quick therapy is going to work for personality disorders. Okay. Psychodynamic therapies, I think if they're more long-term intense, can be good. I think DBT is good, maybe in a little bit longer than CBT run, but again, I think the long-term studies of DBT are still lacking. That may have changed, I don't know. If you know different, let me know. But again, I'm a little biased. I'll admit my bias towards psychodynamic therapy here. But that's because that's what I was trained in. Again, this is DBT, details about it. You can leave those yourself. Psychodynamic therapy, we could talk a lot about this if I had time, go into it. But there's been some studies looking in this, and they seem that there's some effective treatments. But they're just long and intensive. Okay. I'll let you guys read this on your own. Okay.